Bueno, pues pasaríamos a lo que sería la segunda charla. Me vais a permitir que sobre el VIH no voy a hacer yo ninguna reflexión, pero sí una reflexión sobre el envejecimiento, que está tan en candelero por varios motivos en este momento, ¿no? Motivos económicos, sociales. Pero en lo que nos afecta, yo creo que las sensaciones fuertes, como decía José Ramón ayer, se encuentran en la investigación sobre todo y posiblemente vayan a llegar a la asistencia en un futuro cercano, ¿no? Un poco en el envejecimiento nos está sucediendo lo que en los 90 en el VIH que veíamos, pero no podíamos hacer nada. En ambos casos creo que está suponiendo una pequeña o gran revolución. El factor común o factores de riesgo para muchas enfermedades es la edad. Y esto está haciendo que un número importante de investigadores, fundamentalmente a nivel básico, estén pasando de su investigación en oncología, en cardiología, en neurodegeneración, a investigación propiamente en envejecimiento. Si nosotros vemos aspectos del CENIO, del CENIC, del propio Albert Einstein, vemos cómo se está produciendo esta evolución y seguro que os vienen nombres a la cabeza que están haciendo esta transición, porque al fin y al cabo están investigando prácticamente lo mismo en muchas situaciones. Esto está llevando también a interacciones entre diferentes agentes que hasta ahora no se hablaban. Un neurocientífico, un neurólogo que pensaba en la neurodegeneración con un oncólogo, pues justo se podían saludar en un pasillo. Y no es menos que el Premio Nobel de Medicina de este año ha caído sobre un japonés, Yoshinori Ohsumi, el cual ha investigado sobre envejecimiento y ha investigado sobre autofagia, uno de los pilares de los 10 hallmarks que se han definido en el envejecimiento. Y hay instituciones, tanto en Europa, como por supuesto en Estados Unidos, en Europa, que tienen estrategias transversales de envejecimiento dentro de sus planes de investigación, en los cuales coinciden muchas de las áreas verticales. Si pasamos a nivel clínico, la detección de la fragilidad y sobre todo de la prefragilidad, un sitio en el que todavía se puede intervenir, puede alargar el periodo libre de síntomas. Por ejemplo, nuestra sociedad es una de las que más vive y, sin embargo, entre los 10 y 13 últimos años vive fatal, ¿no? Por lo tanto, lo que tenemos que intentar es, primero, no alargar tanto la supervivencia, sino alargar ese periodo libre de síntomas. Por primera vez, la FDA aprueba un ensayo clínico para envejecimiento, que lo va a llevar Niels del Albert Einstein, y probablemente en poco tiempo va a aprobar otro liderado por Felipe Sierra. Los estudios de centenarios y nonagenarios están aportando muchas luces en este camino. Gente que llega a estas edades prácticamente sin patologías. En el lado opuesto, y va a ser lo que nos va a ocupar, aunque no establecido claramente, hay poblaciones que tienen un envejecimiento temprano y que puede redundar también en un incremento de conocimiento. Uno podría ser la distrofia miotónica y, sobre todo, lo que es la infección por VIH. And about that will be the talk of Professor Niels Obel, entitled HIV Infection and Aging. Professor Obel is coming from Denmark. Is medical specialist in internal medicine and also in infectious diseases. Is clinical responsible of the infectious diseases unit in the Copenhagen Hospital, and present is associate professor in internal medicine and clinical epidemiology at the Copenhagen University. He has been involved in several research projects in the field of HIV infection. He has been author of more than 200 peer-reviewed papers, and in the last period, significantly, in the long-term mortality in HIV-infected population 50 years or older. Professor, thank you so much to be here today, and now it's your time. Thank you.
So first of all, I want to thank the organizers for inviting me to this place. I recommend you never to be head of a cohort. It's a large trouble. But there are nice things about it, and that is that you're invited to those local or national conferences, and they're always placed in very nice cities, and that's also the case in San Sebastian. And then you don't understand the rest of the presentation, so you have to walk around in this nice city, looking at museums and small restaurants in between. So that's very nice. Didn't we have a... Oh, there, sorry, thanks. So I'm going to present data from the Danish HIV cohort study, as that's what I know most about. It was started out almost 20 years ago, and I think I didn't understand or imagine that I should stand 20 years later talking about HIV people getting old. At that time, the problem was that they didn't get old. So we're talking about aging, and I don't know what it is really. There are many aspects of aging, and it has been in many clinical reviews during later years, and almost as if it was a problem that these people got older. I don't think it's a problem. It's really difficult to manage in epidemiology, and it's, this is one example where they have looked at the age where you get cancer in the United States, and as you can see, the red and this black one, I think it is, I can't see from here, there's difference between the ages when you get a cancer in the HIV population and in the background population. But that's not because there's a difference. That's because there's a difference in the age of these populations. And when you correct it, you get exactly the same in the HIV population as in the background population. So it has something to do with the distribution of these populations. And that's one of the big problems in trying to find out what's going on with aging in the HIV population. And also there are timelines seen from the point of view of epidemiology. You have the age, but you also have calendar time. You have time since we don't know when they're infected, but at least we know when they're diagnosed, and we know when they started the antiretroviral therapy. And that's really a problem in epidemiology whenever you have timelines. One timeline can be difficult to handle, but 4 timelines at the same time is really difficult. So now we'll go to the Danish HIV cohort study. And why should we have a Danish HIV cohort study? I think we started out simply, as Winston Churchill said, because we only believe in the data that we doctor ourselves. And also sometimes we look at something and we think we know what it is. But when we get a closer look, we find out it's definitely something else. And I think that's why we should be a little humble when we look at data and try to find out what's in behind these data. This is Denmark, and it's essentially a peninsula and 2 islands, and Copenhagen is over here. And most of the HIV patients in Denmark are living in Copenhagen, so that makes it a lot easier to make a cohort in Denmark. And now we started out with 25 patients, and now 20 years later we have more than 7,000 patients, and I think the distribution is quite similar to what you see in the rest of Europe. We have around 10% who are IV drug abusers in the population, and that already shows us that this population is different from the rest of the background population in Denmark. Then we have something unique in Denmark. In 1967, all Danes got a PIN number to identify themselves. It was the date of birth and another 4 numbers, and that was how it was in 67. It would never be allowed today, and you could even see what was the gender of this person. It would never be allowed today that you had all this information in the number. And we had this for many years, and I have always said that's not a problem. But I have to admit that now it's maybe become a problem because we have all these computers and all these data are running around now, and we don't know where they are. And then we can have this Danish HIV cohort, and we can couple it to a lot of other registers which have been in Denmark for many, many years. The Danish civil registration system, where they know where all people are in Denmark, whether they have immigrated and so on. The Danish hospital database, where everything in the hospital is put into. And we have the Danish cancer registry as well, where we can see whether people have had cancer, what kind of cancer it was, and what stage it was in. We also have social registers where we can see what kind of education you have, what's your income. You can even see what mark you had in school in Mars some years ago. So you really know a lot about the Danes, and also if they died, why they died. So how is it going with the AIDS in the HIV population? This is from 1995 when we started out to 2014, and this is the median age, and you can see it has really gone up in those years. This is a distribution, and what you have up here is those 70 years older, 60 years, and so on. And you can see the distribution has changed a lot during those 20 years. And for the purpose of this talk, I made this one, where you can see how the distribution was when we started out, with most people being around 30 and 40 years. And now this is the 1st of January 2016, and you can see most people now are a little older or old at the moment. And of course, this was the whole purpose of the antiretroviral therapy. But I think in Denmark, the huge epidemic in Denmark is old HIV patients. It's really growing in these years. How is it going with mortality? Then we have the possibility to have the HIV patients, but we can even go to those registers and get some population controls who has the same age, who are born the same day, has the same gender, were alive. This HIV patient became diagnosed with HIV, and then we can follow these patients and see how are they dying and what way should they be supposed to die. What is the death rate in the background population? And this is one of the publications from Denmark, where you have a 25-year-old man or woman, and then you follow them in a mathematical model. And this is the background population. This was how it was in Denmark around 1995 to 1996. And then you can see how the age or how the survival has increased in the Danish HIV population. And at that time, in 2005, it was around 65 years, the median age at that time. So it has really increased by around 35 years, but still something was left. This is how it was when we divided the patients on risk groups, and we had some that were abusers, some were comorbidity, some who were either late presenters or did not take the medicine, and the rest. And you can see, in case they didn't have comorbidity, abuse, and they took the medicine, their risk of dying was almost or equivalent to the background population. So I think that if you only have HIV as a problem, you're probably rather close to the mortality in the background population. What was really impressing in some way was that 2/3 of the patients, they were down here. So it is in fact a small part of the Danish HIV population that's on this top up here. And this is a figure we made recently to try to follow up on this study and to see whether we still increase life expectancy in the HIV population in Denmark, and we do. And I don't know exactly why we are, because I think the treatment has been very good since around year 2000, but something is still changing, and they are coming closer and closer to the background population. Some has asked whether they could have a life expectancy that was longer than the background population, and I thought that was a crazy question. But maybe it's not, because I'm pretty sure that those that's alive in Denmark now in some way have survived, because they are, there's a survival benefit. So we could end up that the good HIV patients, they live longer than the background population. So what is aging? We know something is associated with death, disease, fragility, dementia, even wrinkles, diabetes, prostate, cataract surgery. We haven't counted the wrinkles, but we know everything else about the Danish HIV patients. But it's also associated with something else, and that's smoking. And that's one of the things we have realized going down into the data. That is that smoking is probably a huge problem in this HIV population in Denmark. This is a study that was made by Maria Helleberg, where she looked at the Danish HIV population and divided them in smokers and non-smokers, and we got access to the background populations where they knew about smoking habits. And the upper curve you have here is what is expected from a 35-year-old Dane that's not smoking. This is a Dane that's smoking. This is an HIV patient not smoking, and this is an HIV patient smoking. So it seems as if smoking is really something that decreases life expectancy. Of course it does in the background population, but it decreases life expectancy a lot in the HIV population. We don't know exactly why, but our impression is that a lot of them smoke, and they smoke more than they do in the background population. And it took away around 12 years in the smoking. Smoking took away around 12 years in lost life in the HIV population, while HIV only took away 5 years. And as you could see, being a smoker and having HIV is almost the same risk in the Danish population. We have used this to try to convince our HIV patients not to smoke, and I thought it was impossible, but it's not. It was possible it is really possible to make them quit smoking. We can jump over this. This is how they die according to what level they have of education. This is HIV patients with a high level of education, and this is with a low level of education. And when we saw this, we thought, oh yeah, that's because they're not able to take their medicine. They're not able to go to the doctor. But that's not the case. This is time from when they fulfill the criteria in the guidelines in Denmark of being treated and when they were treated. And it's the same whatever kind of education you have. And when it comes to undetectable viral load, when it comes to increase in CD4 count, it's exactly the same. So it has nothing to do with the HIV infection that they're dying more when they're coming from lower social levels in Denmark. And then we went to the background population, and you can see exactly the same, that those with a lower level of education, they're dying more than the other ones, exactly like it's in the HIV population. It only shows that the HIV population is becoming equivalent to the rest of the Danish population. We can skip this part. Yeah. We have talked a lot about cardiovascular diseases as well in Denmark. And in this case, we can go from the HIV patients to date of myocardial infarction in the Danish hospital database, and we can do the same with the population controls, and then we can see whether they have an increased risk of myocardial infarction, and they have compared to the control subjects. That was new at that time, back in 2007, but now it's common knowledge. But again, we went to the smoking, and what you have here is down here you have HIV patients that's not smoking, and the background population not smoking, and the risk of having a myocardial infarction. And it's almost the same. But when you go to former smokers and smokers of the HIV patients and the background population, you find out that the risk of getting myocardial infarction in HIV smokers is higher than it is in smokers from the background population. We don't know why this is. It could be because there's some interaction between HIV and smoking, but I think the explanation is a lot more simple. It's simply that they smoke more, the HIV population. And we could find out that almost 3 out of 4 myocardial infarctions in the HIV population was attributable to smoking in this population. So that's a lot. And we could even go to the parents of these patients and controls and see whether it was the same pattern in the parents. And it is. These are the mothers of the control subjects. These are the mothers of the HIV patients. And this is time to their first myocardial infarction. And as you can see, the mothers of the HIV patients, they have also more myocardial infarction than the background population. So these patients, they stem from families where you have risk factors for myocardial infarction. We can skip that and go to the cancer. What about the cancers? This is lung cancer in the HIV population. This is lung cancer in the background population. And yes, it is increased, but it's all smokers. And when we go to the mothers and fathers, yes, their risk of lung cancer is increased as well. it has probably nothing to do with HIV. It has something to do with the lifestyle these patients have. And when you go to head and neck cancer, this is head and neck cancer in the HIV population, this is in the background population, and when you go to the fathers and the mothers, you see exactly the same pattern indicating it has something to do with another factor, and again, my guess is it has something to do with smoking. Also, when we looked at other cancers, we tried to divide the risk of cancer in smoking-related cancers, lung cancer, head and neck cancers, and so on, virological cancers like Kaposi's sarcomas, and the other cancers. And then we tried to find the relative risk. And as you can see, they had twice as high a risk of cancer, but it was all smoking-related and virological cancers. When it came to other cancers, the risk was exactly the same as in the background population. Then we tried to find out what about all this becoming older earlier. And one day I said to one of the PhD students, why not look at cataract surgery? As far as I know, cataract is something related to being old. And she did that, and she was happy and came back and said they are also operated more for cataract. Yeah, you can see it was even published in Clinical Infectious Diseases. I don't know if that was fair. I think it was a, a strange kind of result, but it was. Later on, I have been taught that even cataract surgery is related to smoking as well. So maybe we did look at something that was wrong to try to find out if they were older earlier. This is low energy fractures in those with IV drug abuse in an HIV population and in the background population. And you can see they have a little higher risk of low energy fracture in the HIV population compared to the background population. When it comes to high energy fracture, they didn't have that. But now I have been learned as well that this is also related to smoking habits. And we have tried to correct this for smoking, and then there's nothing left. What about dementia? Yeah, this is dementia risk in the HIV population. This is in the background population. And we have been told that these people should be heavily demented early. That's not what we see in Denmark. They are not demented. Then it came to diabetes, and nobody has convinced me yet that diabetes is related to smoking. And this is the risk of diabetes in the background population and in the HIV population, and we didn't see any difference. And when it came to prostate hypertrophy, this is the HIV population, and this is the background population. So they even got less prostate hypertrophy in the HIV population. Then we thought that's maybe because they're not going to the doctors. So let's see whether the fathers have less. They have exactly the same as the background population. So when it comes to those age-related diseases that's not related to smoking, it seems as if there are no differences. Then we did this study where we tried in some way to take a population the same age over calendar time and to see whether something happened. And this was one of my PhD student, Line Rasmussen, who worked together with Margaret May, which some of you maybe know in Bristol, to try to do this. And they are two very clever women, both of them. And of course, it was this that inspired them to do the work. And it's really difficult to do that kind of analysis. This is a risk of myocardial infarction over age. And this is the HIV population, and this is the background population. And of course, it increases with age. So the question is it more dangerous to be an HIV patient down here or up here? If you calculate the relative risk is highest here, but the risk difference is highest here. And I don't know when the risk is highest. Is it the relative risk or is it the absolute risk? Has you ever speculated why we always use relative risks? I think it's because you can make a regression analysis on relative risks. You cannot do that on absolute risk differences. So you have to look at relative risks and you have to look at absolute risks in the same study, and then you have to try to compensate for this population getting older. And what they did was that they standardized the risks. So they tried to find out what is the risk in different age groups, and then they put that on a population, and a theoretical population, which has the same age through the whole study, and then they tried to find out whether there were any differences. That's what you have here. And you can see, no, there was no differences. This is time after HIV diagnosis. It was completely flat, and also the absolute risks were the same when it came to time after HIV diagnosis. And that's maybe not what we expected. This is over time, where you have the same, they had calculated the same way, and the green one are the controls, and the blue one here are the HIV population. And as you can see, the risk is in fact going down. It's not going up over time, over calendar time. So it seems as if these risks are not increasing, they are maybe in fact falling. So again, we have these 4 timelines, and where we wanted to look at calendar time and try to eliminate the age, and again try to maybe also look at time since HIV infection and time since ART initiation, as somebody tells us that it's dangerous to have antiretroviral therapy, as it will increase some of the diseases. And this is a little complex. She looked at myocardial infarction, stroke, virus-associated cancers, smoking-related cancers, other cancers, severe neurological deficits, chronic kidney disease, chronic liver disease, and osteoporotic fractures. And as you can see, of course, the absolute risk is going up for these diseases as you become older, but the relative risk is going down. Then she looked at calendar times, and I don't know if you can see it from the back rows, but this is 1995 to 1996, and this is 1930 to 1940. So this is calendar time. Has it changed over calendar time? And as you can see, these are the same groups of diseases with myocardial infarction, stroke, and cancers, and so on. And as you can see, the risk has not increased. If they had done some of them has maybe even gone down. And at the same you can see here, where you can see the relative risks, they have not increased. They have, if they have done something, they have gone down. There is a problem with chronic kidney disease, which I think is over here, and nobody can explain, but it seems as if it's going up in Denmark, and as you can see, it's also going up in the background population. It may have something to do with Danes are becoming older, and in Denmark, if you go back 20 years ago, if you were old and your kidneys were bad, you simply died. Now they keep people alive even in their 80s and 90s, and they go to the Department of Nephrology and have dialysis in a very high age. But the main conclusion from this was that we couldn't see any increase in these diseases. We could in fact see that they were probably going down, both on the absolute and relative risk scale, but they were absolutely not going up. Yes, and this is the same where it's time since the start of heart. We couldn't see that these curves were going up, which was expected 5 or 10 years ago. So this is not the case in Denmark as far as we could see, and we can skip this one. Are we the only ones who have seen this? No. This is from Kaiser Permanente, and you can see that's for stroke and for myocardial infarction, and you can see the same thing. Something is happening, and we are coming more and more close to the risk of diseases in the background population. We are not having more and more diseases. So what should be the conclusion of this talk? I think it's very difficult to conclude on age. But yes, the population is becoming older, but that was the purpose in 1995, 1996 of CART. Yes, they have a higher risk of some non-age defining diseases, but and this could be interpreted as they are becoming older earlier. But the absolute and relative risk of most diseases are going down with calendar time. Much of the comorbidity in the HIV population is related to non-HIV factors like mainly smoking and drug abuse. And I don't know if it is a little provocative, but I think the main goal is to make the HIV patients nowadays perceive themselves as healthy and well-functioning individuals and not to induce unnecessary concerns when they become older. Sometimes I can have the impression that every time we solve a problem for the HIV patients, we find a new one. If they're not demented, they need to have cancer. If they're not having cancer, they need to have some other diseases, renal diseases or whatever. They're not allowed to have a normal life. So yes, we're going to see very old HIV patients in the future. And that's probably, we should probably be happy about that instead of finding that it is a problem. Thank you.
Thank you for the great talk. We will have time for 2 questions because we are out of time. Antonio?
Thank you for excellent talk. Sometimes when studying aging in HIV, it's difficult to differentiate 2 kinds of population. Those HIV people who have been infected for a long time and where we are seeing some comorbidities, and it's difficult to differentiate the role of HIV infection and the role of toxicity due to all drugs and all that. And the other population is those patients who are diagnosed later, so late presenters with age, in which maybe you can see more defect of HIV. And these still are an important population because, at least in our country, nearly 50% of patients are presented late. So have you had the opportunity of differentiate these 2 kinds of population and to see if HIV has a role in one of them?
Yeah, it's really a huge problem. What we see is that, of course, in the initial phase of the HIV disease, there's lots of problems with late presenters. But if they are treated for some years, it seems as if they're coming back on track with the other ones, if that was an answer to the question. But that's some other studies than I have presented here. But we have looked at that, yes.
Yes, looking after frailty or fragility is becoming a remarkable tool in non-HIV patients. What do you think about following the frailty or pre-frailty in our patient clinics?
Frailty?
Yes.
Yeah. So the question is, what about frailty?
Now in non-HIV patients, it's becoming in the primary care of people with more than 65 years old to measure the frailty.
Yeah.
And dividing the patients in pre-frail, frail, and that is becoming a tool to follow patients because we don't have any armamentarium to give them, and they have the risk to have of hip fractures or becoming a new cancer or apparition of neurodementia. What do you think about that in HIV patients?
I don't know if it should be different from other groups. I think we should try to do the same with the HIV patients as we would do with everybody else, if that was an answer. Yeah. I don't think we should make something special about the HIV patients. And, you know, in Denmark, just being a male increases your risk of death by 70%, all lives true. But it doesn't send us to doctor every 3 months.
Yeah. No, here it's becoming a tool who is trying to quantify the frailty.
Yeah,
because it's really it's not too objective to measure the frailty. But there are some tools now with with good results and are implementing in non-HIV patients.
Yeah, but I think if you implement them in Spain, in general, of course you should implement them on HIV patients as well.
In research here in Basque Country and some other in Getafe in Spain also, and now it's a big budget from the World Health Organization about to measure frailty.
Congratulations for your talk and for your 20 years of work with this wonderful cohort. My question is, so you have shown us that lifestyle and smoking now accounts for a lot of, is a driving force or is an important factor in aging and non-HIV related comorbidities. What have you studied other variables related to lifestyle, such BMI or what you eat, exercise, you know, but in particularly body mass index, because this is, you know, we have in our patients, they smoke a lot, they eat a lot, they don't exercise, they are fat. So have you analyzed these other factors?
The short answer is no. The little longer answer is that a strange thing is that it's, you know, we have all the patients in the database. And one thing that's never measured is height. We don't know how high these patients are. We maybe know what their weight is, but we don't know how high they are. And it's very difficult to make doctors measure how high a patient is in Denmark.
Here. ¿Puedo?
Last one.
Thank you. Niels, I'm here. Hi.
I can hear you at least.
I'm here. Hi. Hi. Hello, Niels. Thanks very much for your talk. This is just a provocative question, and we know we're running out of time, but you've said that there is a risk that your Danish unique identification number is being threatened. Is this going to disappear, or will we keep being very jealous of the Danish epidemiological system that allows you to cross-match all your registers in a very efficient way?
So your question is whether we can go on with this?
Well, you said that this is the kind of thing that wouldn't be possible anymore, and that you looked worried about the future.
Yeah, we look worried about the future. It's still possible, but there are coming some new rules from EU, and now it's almost going to be politics and not science, where they try to stop this. And I don't know really what I should mean about it.
I think you have shown such a spectacular production of your system that this would be one of the examples of why these EU rules are not meant to stop research.
It should not stop the research. And we have a huge discussion in Denmark about these things at the moment. And it's very, very difficult to explain to people that one thing is to have the data in a computer. That's one thing. The other thing is to use them for science. And I think it's very important that if you put the data in a computer, that they can be used for science. Whether or not you should put them into the computer, that's a political question. But not that you should really be able to use them for science. And one thing that is dangerous, in my opinion, is that if you allow administrators and political people to analyze data, but you not allow scientists to do the same, then they can tell you whatever. Yeah. Because you can't control that.
Yeah. Thank you very much.
Either or.
Yeah.
Was that an answer?
Yes. Yeah.
Thanks.
Thank you, Professor Obel. We are going to finish. Thank you. Simplemente, de la misma forma que hemos empezado, quería sumarme como Pepe Alcamí, pues bueno, que recordemos el día que es hoy y de la gente que estuvo, de la gente que está y de la gente que en medio pues se ha ido sumando o nos ha dejado, ¿no? Nada más. Gracias a todos.